Hey guys, welcome back to the channel. So today we're going to be discussing hyponatremia, so a patient with a sodium of less than 135, and the step-by-step diagnostic evaluation of hyponatremia, because sometimes it can be pretty difficult to figure out what's going on. So it's almost always the retention of solute-free water, but there's lots of disorders associated with it, maybe the problems with water excretion. Anyway, we're going to go through the steps and find out. So the very first step when you have a hyponatremic patient, and you know what, sometimes you know why they're hyponatremic. They're volume overloaded, they're drinking lots of water, but sometimes you don't. Or sometimes they're not responding to the intervention you thought. So we have to go through the steps to kind of figure it out. So the very first step that you need to do if you have a hyponatremic patient is you need to order or ask for a serum osmolarity. The serum osmolarity is going to tell you if you're in a true hypoosmolar state. So we're going to figure out whether it's kind of true hyponatremia or not. A patient with a normal serum osmolarity or an elevated serum osmolarity suggests the presence of pseudo-hyponatremia or increased concentrations of other osmols such as glucose and mannitol. So a true hypoosmolar state, a true hyponatremic patient is going to have a serum osmolarity of less than 280 milliosmoles per kilogram. So if your patient has a serum osmolarity of less than 280, then we call this true hyponatremia, and we can move on to the next step. If it's higher than that, well, maybe check their glucose. It could be something else. Okay, so the very next step after you have determined that your patient is truly hyponatremic is to check a urine osmolarity. What this is going to tell you is whether the ability of the kidneys to dilute the urine is intact or not. So the normal response of the kidney when you're in a true hyponatremic state is to make maximally dilute urine. So they're trying to fix the problem. They're trying to get rid of it. If this is normal, so if the urine is maximally dilute, it means that your antidiuretic hormone is completely and appropriately suppressed. So this is a good thing. So you need to measure urine osmolarity or your specific gravity. So if your ADH is appropriately suppressed, then your urine osmolarity is going to be less than 100 milliosmoles per kilogram. And this indicates normal water excretion. So we're excreting as much water as possible in our urine. Now, this usually only happens in a few scenarios. So the first one is we might be drinking too much water. We call this primary polydipsia, and I'm talking like an excessive amount of water, like 10, 15 liters a day. This is usually a psych issue, and this requires some behavior modification, so drinking less water so that your body can kind of keep up with excreting it. The second time this occurs is something we might, if somebody has a very low solute diet, so sometimes we refer to this as tea and toast syndrome, or if somebody's an alcoholic and they're only really drinking beer all day that doesn't have a lot of solute in it, we may call it beer potomania. But basically what happens is we're drinking too much water and we don't have enough solute in our diet, and we need a minimum amount of solute to get rid of waste. So So if you have extremely poor solute intake from your diet, the ability to excrete excess water is reduced by your poor dietary intake. There's not enough solute load to carry the water out of your body. So you need a minimum amount of solute to get rid of excess water. And because you don't have that amount of solute, you can't really get rid of the excess. So even though your body's retaining water, the urine osmolarity is low because you're trying to excrete the excess water. They're trying to excrete whatever free water they can against an empty solute pool. So when we say solutes, we refer to sodium and protein. So we typically fix this with a higher protein, a higher sodium diet, and by restricting fluid. So it's more concentrated. You get more concentrated blood. A third time this can happen, and this isn't always the case, but something called reset osmostat syndrome. And this can occur over a wide variety of urine osmolarity, so it's not exclusive to this section, but reset osmostat syndrome is where you have a change in your normal plasma osmolarity threshold. So you're usually not symptomatic and you don't really need treatment. And the hyponatremia doesn't get worse. You just kind of sit at your new threshold, or your osmostat has been reset. And again, your urine osmolarity is a variable in this condition, so not always just exclusively to this section. So you can also have a urine osmolarity greater or equal to 100 milliosmoles per kilogram, and in this case, our urine is inappropriately concentrated. So we call this impaired water excretion. So we're concentrating urine. Our ADH is still telling us to absorb more water when it should be telling us to excrete more water. So in this case, we need to rule out hormone disorders. So we need to rule out hypothyroidism. We need to rule out adrenal insufficiency. And we usually do this by checking a serum TSH and an AM cortisol. So we should always rule these things out first, but we can just order it as part of our kind of workup. So the next step is to assess the patient's volume status. Now, this isn't an easy task. So the most common cause is a decrease in volume, or hypovolemia. And the way we figure this out is we need to check urine electrolytes. So we check something called a urine sodium level. If the urine sodium is less than 20 millimoles per liter, then this typically represents hypovolemia. So maybe an AKI or failure, actually, because you're holding on, your body's holding on to water and sodium. So you have low blood flow. Your heart's very weak. You're pumping less blood, tricking your kidneys into thinking your body has low fluid and it's in a hypovolemic state, but it's really just poor circulation. So, and like I said, your urine's inappropriately concentrated. So your ADH is signaling you to hold on to more water and more sodium. So it could be either one of those, and it's important to look at clinical signs too, because we would treat these in very different ways. If it was maybe an AKI, we would give more fluid, but if it was heart failure, we might actually want to give them a fluid restriction and a salt restriction. So really important to look at clinical clues to kind of differentiate why they're being in this hypovolemic induced state. So it's typically a low effective blood flow state, we would call it, or low blood volume, effective blood volume. So our urine sodium can also be increased. So this is typically in a euvolemic patient. So we have a sodium greater than 40 millimoles per liter. We would say this is increased. And this typically happens in something like SIADH, the syndrome of inappropriate antidiuretic hormone. It could also occur in reset osmostat syndrome again. And it can also happen in renal wasting conditions. So the treatment for this is typically salt, tabs, for SIADH, it's typically salt tabs and water restriction. You wouldn't necessarily do that in the other two cases, but for SIADH, that's how we typically treat it. Water restriction below their urine output is typically what you will read in the literature, but very, very hard to do. It can also occur, actually, another point to make is with thiazide diuretics. So it almost never happens with loop diuretics, but with thiazide diuretics it could happen because it interferes with the urine dilution ability. So that's another thing to think about when you have an elevated urine sodium. So just some things to think about, but typically we see SIADH, which we would treat with salt tabs and water restriction. And if it was from thiazide diuretics, we would probably just want to stop the diuretic if we could. So in the next case, what if we have a sodium between 20 and 40 millimoles per liter? What do we do then? Well, this is an equivocal finding. So we need to establish a correct diagnosis. And the way we do that is we kind of do a test. So to establish a correct diagnosis, what you can do is you can give 1 to 2 liters of normal saline over kind of 1 to 2 days. And then you measure their serum sodium level and you see what changed. So if you get a serum sodium greater than 5 or equal to 5, then we would say it's hypovolemia because they improved with the IV fluid. So in that case, we would put it over here with hypovolemia. If you get a serum sodium less than 5, so an increase less than 5 or lower than, or it goes even lower, because that could happen too. Your serum sodium could drop, then we would say it's probably SIADH, because with SIADH, we should never give normal saline because you're going to hold on to the water and excrete the sodium. So you're probably going to make the problem worse. There's also, so even in this case, it could still be reset osmostat. So it still could be reset osmostat, and you would do an oral or IV water loading test. It's SIADH or reset osmostat. Okay, so just to review, the first step you're going to do is check a serum osmolarity. Is your patient truly hyponatremic or not? The second step is to measure urine osmolarity and to see if you're making maximally dilute urine. If you are, that would indicate that your ADH is appropriately suppressed. Or are you making inappropriately concentrated urine? Are you still absorbing that extra fluid? And in that case, we would have impaired water excretion. So we would need to rule out our hormonal disorders, and then we would need to check a urine sodium to figure out and use our clinical skills to figure out the patient's volume status and see where that takes us. So a little algorithm there to help you figure it out.